When thinking about hemodynamics, we really have three main areas that we have to deal with. We have preload, afterload, and contractility. Now, if I say the contractility is on the heart itself, preload would be before the heart or pre-heart. Afterload is after the heart, so we call this afterload. These are the three main areas that we have to interact with the patient. Preload, as a reminder, is anything that fills up the patient. Has to do with volume, so either giving volume or taking it away. So we can give volume by giving crystalloid, colloid blood products. We can take volume away from patients with the use of diuretics, CRT, ultrafiltration, that sort of thing. Or if the patient's bleeding out through a chest tube or something like that. Afterload is everything after the heart. This is the high pressure circuit of the patient's blood pressure, so the interventions in afterload have to do with vasopressors or vasodilators. Drug of choice, it doesn't really matter. We're just talking about the area of influence. Now, acting on the heart itself, can the heart actually produce more flow in and of itself? And with more effort, it can. And there is a drug class called positive inotropes, which allow it to do so. So let's say you have a patient with blood pressure that is low. And let's complicate this to say that they also have congestive heart failure. Now, if I'm going to do a thought process with this, should I give this patient some volume to resolve this instability? Maybe, maybe not. We're taught that this could be detrimental to the patient's pulmonary status and overload. I don't want to risk overloading the patient. So perhaps we should give everyone an afterload drug, which seems logical. The problem with this is that some patients will present to you with low blood pressure, have a history of CHF, and they might be intravascularly dry. So if we clamp down on someone who is intravascularly dry, what happens to the kidneys? Not so great. So the process here for figuring out what the patient could use is determining if they have preload dependence. So by doing a passive leg raise or an IV fluid challenge, looking at stroke volume change, we can determine if the patient is applicable for preload, despite the fact that they may have a history of CHF. So let's say we do a passive leg raise on this patient, and they come back and they're 30%. Now, as a reminder, anything 10% or higher is they are fluid responsive. So it could be used preload to resolve this patient's instability with their blood pressure, and the answer is maybe. So we decide to give 1 liter of volume and reassess. So say after we give a liter of volume to this patient, they remain hypotensive. Blood pressure is still low. So I don't know how much more I can give to this patient, because when I did a PLR, the average amount of volume coming back from the lower extremities is about 200 to 300 mil. And if we got a positive result with that, we may have went well past their capability by giving them 1,000 milliliters. So we repeat the test and do another PLR, passive leg raise, and this time it comes back at 18%. So is this patient still fluid responsive? Yes, they are, because it's 10% or higher. And the patient has an indication for volume because they are still hypotensive. So if we decide to give 1 more liter of volume to try to resolve the blood pressure, and say after that second liter, the blood pressure remains still low. Repeat the test again, and this time the patient is now 2%. So the patient is no longer fluid responsive. You would look at your choices up here, and you would question the benefit of further preload and decide on something else. Now, when it comes to shock, let me show you how blood pressure works. Blood pressure is made up of resistance times cardiac output, which is in liters per minute of your heart. Cardiac output can be further broken down because our hearts are not a continuous pump, they're pulsatile. So we have heart rate, the number of times in a minute, times stroke volume, which is in milliliters per beat. Now let's say that we have a patient who's lost a lot of blood, or they're currently bleeding out, as an example. They're losing volume. What you'll probably most likely see is a drop in the availability of volume, which means that per scoop or per beat, the milliliters might be decreasing because there's a loss of volume. This is going to want to drag down the total flow over a minute in cardiac output. This is a perfusion metric. The body needs this to survive, and so it knows when this cardiac output starts to drop. So a compensatory mechanism we're taught to look for is to say, well, can the heart mount a higher heart rate in response to this lowering cardiac output because the stroke volume is falling? That can happen. However, if the patient's an AFib, it may be an aberrant rate, it's uncontrolled. Maybe they have a pacemaker, they're stuck at 60. Maybe they have other disease process where this compensatory mechanism is already enacted or unavailable. So if the stroke volume continues to fall, as I just showed an example, then cardiac output would continue to fall, and like turning down the faucet of a hose, the pressure in that line will begin to fall, which will now drag down the global blood pressure. The body obviously needs blood pressure to survive as well, and it recognizes this and will also take an act to try to compensate here as well. So the vessel walls can contract or dilate, and if the patient's body can contract, or we do it for them with vasoactive drugs, we try to increase the vascular resistance to try to raise or combat the hypotension. Now, if this doesn't happen or not enough, then blood pressure continues to fall, and you might actually see a result in lowered MAP. If you overlay this on time, and I said here is a decreasing stroke volume from here, and I compare that to the opposite top end of this tree, you might see something like this. As stroke volume falls, these compensatory mechanisms try to protect the MAP until the MAP falls. So stroke volume is an early indicator of hemodynamic instability, and blood pressure is a late indicator. This is a form of shock, and you'll see this in two types of shock. We call this hypovolemic shock and cardiogenic, or heart failure. So in this case, we had a patient who had a loss of volume that created this cascade. However, if we didn't have that and say it was just a heart pump issue, if the heart is having an MI or it's struggled or it's in failure, again, the forward flow of the stroke volume would be poor, which the cascade here would follow the same route. So it would start to slow down because there's less mils per beat, and it's not because of volume, it's because the pump is not working very well. Cardiac output begins to fall, heart rate may try to increase to pick up the slack, it may not get enough, blood pressure may begin to fall, and again, increase in resistance may try to protect the MAP. Resistance can be measured. So we can measure stroke volume, we can measure heart rate, we can measure cardiac output and blood pressure and MAP. What about resistance? How do I know if this is happening, if this is trending up or down? There are metrics called systemic vascular resistance. There's also one called total peripheral resistance. There's other various versions. TPR, TPRI is the version that we use. We covered hypovolemic shock and cardiogenic shock. There's another form called distribution shock, and it's very common. I'm going to show you why. So blood pressure, again, in this tree, is broken up into resistance and cardiac output, which is broken up again into heart rate and stroke volume. Distribution shock, especially coming from sepsis, creates a vasodilatory effect from the inflammation from endotoxins. Now, this doesn't come from stroke volume like hypovolemia and cardiogenic shock. Actually, the problem arises here. So if the patient has low resistance because they're vasodilatory, that will cause a drop in blood pressure. But there's an inverse relationship between flow and pressure. So with an immediate response with this, as blood pressure drops due to the resistance falling, cardiac output will naturally increase because there's less resistance for the heart to do the same amount of work. On top of that, due to the fact that the body is struggling for O2 at the tissues, it sends signals to the heart that it needs more perfusion. And so the heart will basically run. You will have an increase in rate and an increase in effort, which will also make cardiac output go very high. So in early sepsis, you might see a patient with high cardiac output with low resistance, poor blood pressure, or adequate blood pressure. This is called hyperdynamic or vasoplegia. I'd like to introduce a few metrics for us to consider because we're going to go through a small clinical scenario. So let's say that we have heart rate and stroke volume, and we know that when we put those together, we get cardiac output. Heart rate is in beats per minute. Stroke volume is in milliliters per beat. So our overall finish will be in milliliters per minute. But in cardiac output, we don't look at that. We bring the decimal point over and look at it in liters. So cardiac output is always looked at in liters per minute, volumetric flow. The normal range for cardiac output is 4 to 8 liters per minute. Now, if you had normal size adults, this information could be useful. But sometimes you walk in a room, patients are larger or smaller, maybe you have Shaquille O'Neal. If you have different size body, you have more body surface area to feed. So sometimes this can be a little misleading, especially in developing shock or hyperdynamic states. So how can I look at a cardiac output as easy as I look at blood pressure and map? Maybe we already know that a normal blood pressure is 120/80 with a map of 65. Cardiac output we're not used to looking at. Sometimes it's not always evident, depending on the patient's size. Is this adequate for their perfusion? So there's an easier way to read this. There's a sister measurement from cardiac output called cardiac index. The index includes the body surface area in this calculation and levels the playing field so that we can apply cardiac index as a reference point to all patient sizes for adults. So cardiac index, the normal range here is 2.5 to 4. And we're actually looking at this in liters per meter squared per minute. It includes the body surface area. So let's say that you look at your cell phone and you have the signal strength bars on the top right corner. Now, I know how to read this. I can look at this and say if I only have 1 bar, I know they have poor signal quality. I know if I have 4 bars, the signal is really powerful. This is easy to see, and I can understand this. But this is not how cellular technology works. It's similar to this. It's the way for me to understand as an index that I understand that I have good quality signal. That's what cardiac index is. So if the cardiac index on your patient is within this range, 2.5 to 4, then I know that whatever their true output is doing, if I currently measured that, is good for them, for their size. That's what this is telling me. Okay? So there's another tool I want you to look into. It's called TPRI, Total Peripheral Resistance Index. The normal range here is 1970 by 2390. And this is a measurement of afterload. Okay, so remember preload, afterload, contractility. As the heart pushes out against your blood pressure, there is resistance because you have pressure. And that can be measured. That's what this represents. So if this TPRI is in that range, you could assume that there's normal resistance here. Now if we go back to our patient here, so blood pressure is our blood pressure tree. Blood pressure is resistance times cardiac output, heart rate times stroke volume. Now if we create this hypovolemic patient again, stroke volume goes down because there's volume down, loss of cardiac output, heart rate may increase, may not. It's going to drag down my blood pressure, and a compensatory mechanism here might be to increase the resistance, which will try to hold on to the blood pressure. This is where TPRI is measured. And I can measure this here. So if I see a rise in TPRI, I can say that there's been an elevation of afterload resistance. Now the patient can do this intrinsically, or we can do this with vasopressors, or we can steer this down with vasodilators. This is how you steer your patient. So let's consider a few of these things. We're going to consider the blood pressure, the MAP. This has to be adequate. We have to consider cardiac output. Is this good for perfusion for my patient? Are they within the index for their size? And then is the body working a compensatory mechanism for resistance to hold on to blood pressure? Another thing to think about too is a disease process of low resistance would be something like sepsis or shock. So let's look at the patient. Let's say you come across this. Take a moment to kind of look at these metrics and see what you do not like. So I'm looking at this and I see, I remember my cardiac index, that's a little low. We have our normal ranges. So our normal range for cardiac index was 2.5 to 4. This is a little low. Global perfusion's down. I see my blood pressure is a little low. So we have poor map and poor flow. I see that my heart rate is kind of tachycardic. It's kind of elevated. It might be because the stroke volume is down, trying to compensate to carry this. This number, the TPRI, the resistance here, is slightly elevated to protect the map, but it's not doing a good job. So we have a problem here. This patient needs our help. So what are our options? Well, right here. Here's your toolkit. Preload, afterload, contractility. Which one would we choose? Which one would be appropriate at this time? So, if you said to do a PLR first, you are correct. I would prefer to give a patient volume if that's really all they needed, but how do I know if this patient could tolerate it? By doing a passive leg raise. Here we are. I did a change of SVI. So as a passive leg raise, it was 16.2%. So we say, is that 10% or higher? You go, yes, they are fluid responsive. Could this patient tolerate some fluid? Of course. So let's decide to give this patient some volume and say this is what they resolve to. So I can see here blood pressure did come up a little bit. Cardiac index came out up a little bit. But we're not quite where I need to be. So we gave the patient some volume. It could be 500 or a liter. This is just a thought experiment. How much more can this patient tolerate? Do I give more? So an important thing here is I don't know. We mentioned earlier through the exercise of the patient with CHF that we would like to repeat a test. And so let's do that here. So let's repeat the test and repeat a PLR, and we'll see that the change of SVI is now 3.6. It's dropped below the 10% mark. So we gave the patient's volume, and not much more is coming out the other side. So my options here, preload, afterload, contractility. I might question the benefit of volume here and say, is there an opportunity to use positive inotropes or maybe some afterload drugs, a pressor? Now, I'm going to go against what might be the correct answer here and show you what you might see in reality. Most of us are hyper aware of blood pressure, but maybe not as comfortable with cardiac flow. So the indication here might say, well, this patient needs a vasopressor because we need to get the blood pressure up, which may work. So what do vasopressors do? They increase vascular resistance. Your afterload. This is what we're going to tap into. The afterload resistance that we're measuring is already elevated. So if we decide to give the patient a vasopressor, say start them on some Levophed, this is what you might see. So a rise in resistance creates a rise in pressure. So it did exactly what it was supposed to. However, if you remember, I said there's an inverse relationship between pressure and flow. So as we step on that hose to increase the pressure in that line, the forward flow may be sacrificed. Vasopressors aren't free. In response to this, we see an increase in heart rate. So before it was 110 and now it's 120. So the patient's compensatory heart rate is now increasing even higher. TPRI is really elevated. Total forward cardiac index and output is poor, despite the fact that we have good blood pressure. So what's happening to the kidneys here? Interesting kind of thing to think about. So again, preload, afterload, contractility. That's the only three choices to play with. So we ran in a room with preload. We tried some afterload, and yes, we may have risen the blood pressure here, but as the saying goes, Levophed leaves them dead. Now we're aware of this. Maybe we can control and try to help the cardiac flow. Maybe this patient is a candidate for positive inotropes. So let's try some of those. We turn on some milrinone, some other kind of your favorite drug. We increase the the performance of the heart, turn up the flow of the heart, and it will build better forward flow and better perfusion, better blood pressure. Now, as you can see, as the stroke volume is improved, forward flow is improved, the afterload resistance can normalize, the heart rate can slow down, and then it's building more blood pressure, and sort of we've recentered the patient. So the whole story with this is that we use preload, afterload, and contractility as our toolkit, guided by this change in stroke volume to center these.